Good morning, everyone. Thank you so much for coming. We're so excited you're here. So I'm Emily Gallagher. I'm a pediatrician in the Craniofacial Center. I'm the medical director for the 22Q program. And this event is something that we have been talking about for many years, and we're so excited that we finally have the opportunity to share this day with you. I do want to invite Stacy up here with me, who has helped a tremendous amount. She has a few things to say as well.
Hi, good morning. We're so excited to have this opportunity to come together and learn as parents and caregivers of 22Q kids. And I want to start by thanking the 22Q program staff and our other presenters who took the time to be here and who've worked so hard to plan this and put it together. Especially Dr. Gallagher and Joyce Dahl, who isn't here, but just I thought we could start by just a quick round of applause to say thank you. I also want to thank all of you for being here because as caregivers and parents of 22Q kids, you're really busy. You have a lot to do, and so it says a lot that you are here and making the time, so thanks for being here today. And also participating and sharing your experiences and thoughts with other parents. It's so immeasurably helpful to be able to learn from each other in this context, as well as from these experts who are here today. As a parent of a 22Q teen myself, I've found these opportunities so helpful for me on my journey to be able to learn from others and learn from experts, and so I just am so grateful that we get to do this, and I hope that you get to learn and become a stronger advocate and support for your kids from this event. As we go through the content, if you need to take a break, it's a lot to take in it sometimes. Please feel free to step out, come and go as you need to. Just take care of yourselves as you need to through this day, and you'll find in your folders that there are handouts that the staff have prepared to summarize key points or point you to resources. So everybody has those in the folders. And then a few other housekeeping things to share. Please keep hold of your water bottle and refill them. There's a water refilling station. You just go left and then left, so 2 lefts out of here, and you can refill it. Bathrooms and snacks are also that same direction. If you have challenges finding your way, please ask volunteers who are out here, and they can help direct you because it can be a bit of a maze to find, but it's close by. And then again, if you need any assistance or have questions, the team have their badges on and these blue kind of neck lanyards to help identify them, and so they're here to answer questions and help you. And there'll be also opportunities throughout our sessions to ask questions, and then also in our discussion groups as we wrap up the day. So that's it from me, but thank you all so much for being here and looking forward to this day. Thanks.
Thank you. And I do just want to reiterate, we would not be here if Stacy had not helped with this event. She helped a tremendous amount. So I just wanted to give a quick introduction, and this is probably not new information for all of you, but what is 22Q? So this is why we're all here together today. 22Q is the most common microdeletion that we know about, and what happens is there's a region on the 22nd chromosome that's sort of a hot spot for a proofreading error when the DNA is being replicated. And you can have a deletion, which means you're missing some of the chromosome, or you can have a duplication, which is when you have an extra piece of chromosome there. And in this region, there are all these genes that have a role very early in development to help cells migrate to the midline when the embryo is forming. And so because of this, there can be risk factors for any problems kind of in the middle of the body that can be affected. So we know, especially when that DNA is missing, that a number of organ systems can be affected. They're not always affected, but this diagram here kind of shows the different parts of the body that are commonly affected. And so one of the things that we do is think about all the potential things that could be slightly different and figure out how we can best help and support our patients. And you'll hear a lot more about many of these different organ systems today as we go through the day. So our team is quite large because we want to be able to address all the things that can be affected when patients are missing this little bit of DNA. We have nursing, social work, MA, scheduling support, which excuse me, it's early and I've already talked too much. Our core group this really helps our team function well and have everything run smoothly when we're in clinic. We're very grateful for them. We have 3 pediatricians on our team, and you can think of us as sort of like the team quarterback. We're going to be thinking more globally about everything that's going on with your child and try to pull in the right providers who we think could be helpful at different times. We also have support from speech language pathology, occupational therapy, and nutrition, which is incredibly valuable to our team. We are so fortunate to have our immunologist, who you'll hear from later today. We have a genetic counselor who helps educate our families and our patients a lot about the disorder and what's involved and how we can screen, how we test for it and things like that. We have a neuropsychologist who you're going to hear from later today as well. And we have a lot of support from psychiatry and psychology. So we are very grateful that we've been able to pull all these providers together because this is what we feel it takes to provide excellent care for patients with 22q deletion or duplication. In addition to that, we really like to support our families and bring people together. I think, as Stacy mentioned, meeting other parents can be really valuable. Hearing about other people's experiences can help figure out how to problem solve some things that you might be facing at home. So every year we have a day at the zoo. 22q at the zoo is an international celebration. It's always a Sunday in May that's closest to May 22nd. So we've had events for many years now where we bring families together. We have a big picnic. It's close to the zoo. It might be in the zoo this year. We're trying to figure that out still. But that's been a nice way to connect with families. We also have an event typically once a year, sometime in the summer or fall on Whidbey Island at the Embarcy Ranch. And this is an event where families can come together, and I think it's especially wonderful for younger kids because there's a lot of fun stuff that they get to do at this ranch. And then we also have the 22q Facebook group. This is a QR code that will link you to the group if you're not already part of that. But this is another way for families to connect with each other. And hopefully, if everyone thinks that this day is a good idea, we can have some more events like this. So I want to quickly go over the agenda for the day. So in the morning, we're going to have several talks in this room by different providers. We're going to hear more about behavior, vaccines, neuropsychology, and support at schools, transitioning to adult care. And then from that, we're going to have lunch, and it's going to be sort of a grab and go situation because we didn't want to take up too much of your valuable time on a Saturday. But you can grab some food and then head to a discussion group. The discussion groups, we have about 90 minutes set aside for these discussion groups. And we're going to give you prompts every 30 minutes in case you want to change and go to a different discussion group. You don't have to change if you still have more questions that you want to discuss. But these are the topics that we're going to have covered in the discussion groups. We have one that's about nutrition and growth. We have one about psychiatric decision-making, the decision about whether or not to start psychiatric medications. We'll talk about feeding challenges and some strategies, speech and VPI management, and then transitioning to adulthood. And with the exception of psychiatric decision-making, which will be in this room, everything else is going to be right across the hall in Nadella Commons, which is another room, and we can help direct you over there. Also in your folder, there's a piece of paper with a QR code that's a link to a survey. We really value your feedback, and we would love for you to complete the survey at the end of the day. We will remind you to do this as well, but thank you in advance. It really helps us a lot to know whether this event is something that you find valuable and how we can make it as valuable as possible, including what topics you might want to suggest for a future event. So with all of our talks this morning, we're going to have time for questions at the end. So we would love your participation. We have a fun microphone that we get to toss around to make yourselves heard. Okay, so I'm going to invite Dr. Trevino to come up first and talk about 22Q and behavior interventions.
Good morning, everyone. It's so good to see some familiar faces. Hi. So you all probably know me if I've met with you and your family before. If I haven't, I'm hoping that this is a good way to kind of introduce myself and talk about what kind of resource I can be for you and your family. So I'm Cindy Trevino. I'm the psychologist. I'm going to tell you a little bit about myself. So I grew up in Eastern Washington in Tri-Cities, did my undergrad on the other side of the mountains, and then came over to Seattle to do my graduate degree at the University of Washington. And then I left for a little while. I went to the University of New Mexico where I did some of my training, but then came back to Seattle Children's, which is where I started my work actually with 22Q Clinic back in 2020. So I've been with the clinic for quite some time now. And then outside of that, I really enjoy cooking. Recently got into sourdough baking. If you're a baker, please find me and give me some tips. And then I enjoy reading, camping, and hiking. Okay, so this is some of the topics that I'm hoping to talk with you all today. One is I want to introduce what a pediatric psychologist is. That's essentially my role and how it functions as part of the whole team. And then I want to talk a little bit more about behavior, specifically in our 22Q population, and how we can understand behavior. So I'm hoping to share a little bit about a framework that I tend to use when I talk with families about their concerns or behavior problems that are coming up. I'm really using this framework to really understand what might be going on and helping brainstorm with families how we might address that behavior. So we call that framework the ABCs of behavior. I'll also talk about the functions of behavior, meaning why is this behavior happening? How can we understand it? And there are very specific reasons why a behavior might be happening. So I'm going to give those to you so that when you're thinking about your child's behavior and trying to understand it and figure out how do I respond in this moment, you can actually kind of fall back on those functions to help you kind of figure it out. You don't have to do it alone. You can, of course, reach out to several members of our team within psychology and psychiatry, and we can also help brainstorm because sometimes those behaviors can be tricky. And then we'll talk about how we can focus on the antecedents and the consequences specifically in this framework, and I'll talk more about what those are. And then I'll share a specific set of strategies. They won't be all of them, but I'll give you some of the most common ones that you can utilize, and then talk a little bit about some tips and coping for ourselves as parents and caregivers as well, which is important in thinking about and managing behavior. So what is pediatric psychology? So what our role is really to provide behavior assessments and brief intervention for children, teens, and young adults and their families. And that can look in a lot of different ways. Sometimes we get called in if there are specific behavioral concerns that are coming up. Sometimes that's going to be things like defiance or aggression. Sometimes that's going to be anxiety or mood concerns. Those are all kind of categorized as different types of behavior and mood concerns, so we might get brought in to kind of consult on that. Sometimes it also has to do with kids having a hard time coping with their diagnosis or medical condition. Sometimes that comes up at the point when parents start to share a little bit more about the genetic disorder, what it is, and if kids are having a hard time kind of understanding that and kind of incorporating that into what does that mean for my own identity or who I am, sometimes pediatric psychology can help navigate those types of situations. The others might be difficulties with adhering to medical recommendations or procedures. A lot of times it can be like needle procedures, blood draws. Sometimes that might be surgeries or other medical procedures that kiddos might need. And so we might get called in to kind of come up with a plan to help support kids and families through it. Okay, so I'm going to transition us to talking a little bit about the ABCs of behavior and what it is. It's possible I've talked with some of you already. If I've met you, I've talked with you maybe about the ABCs of behavior. But this is a framework that we use or within psychology and psychiatry to really understand what might be going on for a child. And ABC just stands for antecedent, behavior, and consequence. And we can use it to understand behavior, whether it's defiance and aggression. Maybe there's a behavior that's happening in social situations. Maybe it's between siblings. Sometimes it could be anxiety. And so if we're thinking about any of those behaviors, we can use this framework to help us understand that. Before I launch into talking about what each of those mean, I think sometimes it's helpful to talk through, like, why does a behavior happen, right? What causes a problem behavior? I would say that is probably a common question that I get from a lot of parents and caregivers is, why is this happening? And I think it's a difficult question to answer because oftentimes it has to do with a lot of different components. And this figure here is just trying to capture a little bit of that. So when a behavior happens, I often explain it as it could be a multifaceted set of things. One is we have to kind of take into account who the child is, what their characteristics are, what their personality is like. Do they already have a diagnosis like ADHD? Are there learning concerns? What are their interests? What's their motivation like? What are their social skills? All of those different characteristics might contribute to why a behavior is happening or help us understand why it might be happening. The other set of factors that could also play a role in why a behavior is happening is parent characteristics as well, right? Just like kids come into the world with their own set of personalities and temperaments, us as adults, we've developed our own, right? So we come in with our own way of managing stress, our own temperament, our own likes and dislikes, our own supports. And so that can play a role into how we respond or how we might address or react to a child's behavior. And then the other component is what's happening in the environment, whether that's the family, whether that's school, or any other factor in the child's environment. Sometimes that has to do with circumstances, right? Maybe there's changes in the family household. Maybe there's a new sibling. Maybe there's changes in the finances within the family, or there's a move that happens, right? All of these different things together might interact with each other and can result in a new behavior or a challenging behavior that we might see come up. Okay, so as I talk about what the ABCs are, I like to introduce this idea of the window of time. Raise of hands if you've heard this concept before. Yeah, I know my parents here in the front, yes. Anyone else?
I have a question.
Yes.
A handout of the sheet, the first sheet by any chance?
This one?
Yeah.
I think yes, I can provide one. It's probably not in your folders, but I'll be sure to who should I send it to? We'll figure it out, but we'll send it out. Yeah.
I think you have like our mail and
Yes.
email for registration.
Yeah.
It's very helpful.
Okay, great. So the window of time, in a nutshell, what it is I like to introduce it when we talk about the ABCs, because it can help us understand how kids and adolescents think about time. This is not a concept I came up myself. It's actually something that a psychologist and researcher by the name of Russell Barkley talks about a lot, specifically for kids with ADHD. But in a nutshell, what it is that if you think about adults and time, we can often think about the future and the past while we make a decision, right? We're thinking about what happened the last time something like this came up. How did I deal with it? Did it work well? Did it not? How might I change my decision about that in the future so that I get a different outcome? So we have a very complex way of thinking when we make decisions. For kids, that's not really the case. Their window of time is very narrow, and the only thing that is in their essentially in their concept of time is what's happening in the moment and what's in front of them. So they can't always think about the past or the future to inform their decision about why they're going to do something or not do something, which can make it very tricky, right? Which is why we often see that they do things that don't make sense to us, or they do something and you're like, well, the last time they did this, they got in trouble. Like, what happened, right? And so oftentimes the window of time can help us understand that they're not really thinking about their actions in the same way. And that is helpful to have in mind when we think about the ABCs, the antecedent, the behavior, and the consequence. So what an antecedent is essentially what happens before a behavior gets triggered. And that can be different for every kid. Sometimes it might be getting a very specific direction, right? Like being told to stop doing something they like. Sometimes it might be just the environment, like it's noisy, it's loud, there's too many kids. Sometimes it might be related to the child's own mood or feelings, like maybe they didn't get good sleep and they're just very irritable that day or very tired. Sometimes it might also be who's around, or who is the parent or caregiver or teacher who's telling the child to do something specific, right? So those are all the things that happen before a behavior actually occurs. The B is the behavior. Of course, this is what the child is doing. This is what we see, what we observe the child doing. And as I mentioned, it might be aggression, noncompliance, it might be anxiety, like hiding, withdrawing, those kinds of things. And then the consequence is anything that happens immediately after the behavior has happened. So this might be how we react or how we respond as parent and caregivers. This might also be how other people in the immediate area is responding. Maybe it's peers, could be teachers, could be pets, right? All of those other pieces also contribute to what happens after. So this is an example. And I'm using specifically problem behaviors like noncompliance, crying, screaming, because I would say that that's probably one of the more common scenarios that come up. But let's say we have a kiddo who's screaming and kind of throws a remote control. That's the behavior we see, right? Oftentimes, that's the first thing we're going to notice is when a behavior has happened. And it requires a little bit of detective work on our part to start to put the pieces together, to start to figure out what is it that's happening before and what's happening after. And I would say watching it one time might not be enough. You might have to see several scenarios of that behavior coming up to start to put the pieces together. In this case, if I just showed this, the child screaming and throwing the control, it's hard to know what happened before and after, right? In this case, we know the antecedent maybe is that the child was playing and was told to turn the switch off, right? They were playing a really fun game. Now they got to put their pajamas on and go to bed. Now it starts to make a little more sense, right? Why maybe the kiddo is crying and throwing the remote control. It could be that they're not ready to wind down. They don't really want to go to bed. It could be maybe they're scared to go to bed, depending if they're sleeping on their own, the lights are off. We don't know. Maybe they don't want to stop playing the switch, right? There could be a lot of reasons why. Here we see the consequence then is that after the kiddo screams and kind of throws the control, the parent and caregiver in this case maybe responds by soothing the kiddo, maybe saying, oh, that's okay, take deep breaths, calm down. I'll give you 5 more minutes to play on the switch. I kind of paint this picture of the antecedent behavior consequence because the consequence can be very different depending on the parent and caregiver and how we respond. In this case, we can see that there are 2 people that are getting reinforced, or you could use the word rewarded in this scenario. One person is the parent, right? So if the parent soothes the child, says, okay, take deep breaths, you can calm down, I'm going to give you 5 more minutes. If they do that strategy and approach, they're getting reinforced because by doing that, maybe the child calms down and then they avoid a big old meltdown and tantrum. right? And then on the other hand, the child probably also gets rewarded because they recognize, like, okay, if I scream and I throw this remote, maybe what happens is I get some hugs and cuddles, right? My parent soothes me, and I still get more time on the Switch, right? So two people are getting reinforced in this scenario. And that's what I meant by that diagram, that sometimes behavior is very complex because it could involve a lot of different pieces. It's the child's own characteristic, the parent, but also what's happening in the environment, right? So in this example, we can see that all those different variables are coming into play. So how do we change behavior? And I would say that we get the most, probably the most bang for our buck if we focus on the antecedents, where it happens before, and then the consequence, meaning how do we react and how do we respond? Because once a behavior has happened, we probably can't change it all that much, right? Unless we're addressing the consequence. But once it's happened, it's happened. But we can focus our efforts, and we probably have the most control as a parent or caregiver if we focus on those antecedents and consequences, which is what I'll focus some of my time today talking a little bit more about. So I mentioned earlier that there's like functions to behavior, right? I was going to give you the secret hidden messages that you can try to look for in your child's behavior. And they kind of break down into these four. One is sometimes a behavior might happen because your child wants to get attention from you. It could be peers or other caregivers in the home or other adults. It could also be because they want to get something that's more tangible. So it's this idea of, look at me, look at what I have, I want to show you this, or I want that, and they want something specific. The other reason it could be is sensory input or self-stimulation, which is this idea of, this makes me feel good, so I want to keep doing it, okay? The third one is to escape attention or demands, which might be, I don't want to do that. So their behavior, even if they're not using those words, might tell you they're avoiding something very specific. And then the fourth one might be that they're trying to escape sensory input. So it's the opposite of number two. Maybe it's, I don't like how that sounds, or I don't like how that feels. And so their behavior, even though they're not using those words, might suggest that that's what might be happening. So here's an example of this. So let's say that we have a mom who's talking to a friend on the phone or maybe in person, and then the child hits or pinches mom, right? And here the consequence might be mom stops talking to the friend and then tells the kiddo to wait, or might say like, hey, why did you pinch me, or why did you hit me, right? In this case, if we look at one of those four functions, we could probably rule out some of them, right? And maybe the most likely scenario here is access to attention. Maybe they wanted mom's attention. And so that's how they didn't use those words, right? They used their behavior and their body language to say that. So understanding the reason can then help us figure out, okay, what might I be doing differently before I talk to this friend if I know my attention is not going to be on my kiddo? Or how do I respond when they're wanting my attention in an inappropriate way, potentially? Another example might be, like let's say the dad asks the child to greet a family friend, right? Maybe you're out and about, you catch him somewhere, and you want your kiddo to say hello or greet somebody. And then the child maybe runs to hide behind dad, right? And then what happens is the dad maybe answers for the child, like, oh, so-and-so is doing really well, or they're doing X, Y, and Z. In this case, it might be that the kiddo is escaping the demand. Maybe they don't want to greet this other person they saw or say hello. And in both of these scenarios, it's still a behavior, and the reason why it's happening is a little different. Sometimes what can be helpful too is to think deeper into like why those behaviors might be happening, and sometimes that's where we can come in and help. Because in the second scenario, one of the things I might be thinking about is the kiddo nervous or anxious to say hello or greet this other person? And that's why we're seeing this behavior. It could still be related to escaping a demand, but if we know it's anxiety related, again, we might be thinking about different ways to address that as well. Okay, so focusing on antecedents and consequences, I mentioned this is where we get the most bang for our buck. And really it's because as adults, as caregivers, parents, we might have the most control over these two components. And so what I want to do is I want to share with you a little bit about some strategies that you can think about for addressing those antecedents if you're noticing there's a behavior coming up, and then also talk through some consequences that you can use and employ. So the first set of strategies here are what we call the antecedent-based strategies. So this is what you would be doing to try to address the trigger, maybe whatever is setting off the behavior. This is not an exhaustive list. Of course, there are many, many others, especially once we kind of dissect the behavior a little bit more. But these might be a good start. So one is that we could try to focus on making sure that we give very clear expectations ahead of time, meaning we give very clear and specific directions to kiddos ahead of time if we know they kind of tend to have a hard time with a transition or being asked to do something or not do something. So an example of that might mean, we might say first, clean up the toys on the floor, right? Sometimes we have to be very specific which set of toys you want them to clean up. And then we can play, with your puzzles or with your Lego set, something like that. The other could be that you offer choices. So you might say, instead of saying what you want them to do, you might offer a choice and say, do you want to brush your teeth before or after we put on your pajamas? So there you're kind of letting them weigh in, have a little bit of agency, which might reduce the resistance. The other is that you could use routines and visual schedules to address the trigger. Maybe that's a morning or bedtime chart with pictures. I often tell a lot of parents and caregivers that I work with in 22Q Clinic that our kiddos really like visuals, and they benefit a lot from them. So using something like that. Another one could be giving a warning before transitions. Maybe it's 5 minutes. You have 5 more minutes before we're going to clean up. That may or may not work for all kiddos, and some kiddos need more time or more lead up. So maybe you do 15 minutes, then 5 minutes, and then you say when it's time to transition. The other one is changing the environment. So if you know that you have a kiddo who, they get really distracted. And again, if you're thinking about that window of time, you want to make sure that you're changing the environment around them to make them the most successful. Maybe that means you turn off electronics or TV when they're going to work on something where they have to focus on, like reading or homework. Another one might be that you strategically put certain toys and things away when they're going to, focus on one specific activity. The other could be catching the calm before the storm, meaning that in that scenario about the kiddo who wanted the mom's attention while she was talking to a friend, if you know that maybe that's a common scenario, we want to try to catch the kiddo, meaning giving them attention before they're likely to seek it out. So that's what we mean here is give praise before your kiddo's going to act out or try to get attention from you in other ways. So you're preemptively addressing that need of wanting attention before you might get to a scenario where they would be more likely to want to seek it out. And then the other one is to use positive prompts like, use walking feet, please put your feet on the floor. Always, what I say is always saying what you want your child to do versus not to do. And then this slide here has the consequence-based strategies. Again, this is not all of them. But some of the most common ones that we can consider using. So one might be in response to a behavior, you might praise and give compliments, right? And I often encourage families to be very specific about this so that we can help kids connect the behavior with what you're saying they did really well at. So I'm proud of how you handled that situation. And I would even be more specific, right? I'm really proud of how you were able to keep your body calm when your brother took your toy away or something like that. The other is rewards or special privileges. So using things like extra screen time, maybe there's a favorite treat, a fun activity, maybe they get to pick family dinner that night. That list of rewards and privileges can be very vast and very different and unique per kid depending on their interests. The other is that you can shorten tasks as well. So if you're noticing that you have a kiddo who maybe gets distracted easily or can't work for long periods of time, rather than having them work for like 20, 30 minutes, right? And then they melt down after 30 minutes of a lot of math and reading and all that, is that you preemptively say, okay, we're going to work for maybe 5 minutes and then take a break. And then you want to reward that effort, right? We take a break, maybe we go outside, run around a little bit, then we come back. And by doing that, maybe we're increasing the likelihood that the kiddo or adolescent is going to be more successful. The other is loss of privileges. So this would be things like limiting TV time, video game time, time away from a favorite toy, those kinds of things. Logical consequences is another one. So if you notice that there's a behavior that they do where they break something or take something away, maybe you're tying that consequence to that specific activity or thing that happened. So maybe they're responsible for helping you fix the toy they broke or fix whatever it is that they broke. Or if they lose their toys or they forgot to put them away, then you maybe hold off on giving them that set of toys the next time they're playing on their own. And then the other one, which can be hard to do, but can also be effective, is withholding attention in very specific scenarios when you feel like your kiddo is wanting attention. This might be things like ignoring whining. And again, if this is something you've tried before, you're like, this doesn't actually work. Yes, it's tricky to do, and there's some nuances to it. So again, I'm happy to chat with families more individually about this as well. But in general, I say withholding attention can be helpful, but we have to be very intentional about which behaviors we're ignoring and making sure that we're not ignoring unsafe behaviors, because those should never be ignored. And if you have questions about that, I'm happy to elaborate more. The last topic that I want to talk with you all about is just parenting tips and coping. Working with a kiddo who has very specific developmental needs, who might also on top of that have some behavioral challenges or anxiety or learning concerns, and you're having to navigate a lot, it's hard. It's hard. It's not an easy job. And so oftentimes, you probably hear this a lot, is it can be helpful to also focus on your own care and coping for yourself. Sometimes it feels selfish, and sometimes it feels like there's not a lot of time, right, to dedicate to that. And it's just as important because a lot of the strategies that I mentioned require a parent or caregiver to be able to put effort into making some of those changes, which are hard. And maintaining consistency is the key. And in order to maintain consistency, we need to keep fuel in ourselves to keep it going, right? So these are just some images of things that I often encourage families to think about is, we can't water plants from an empty, a bucket or, container from a hose that doesn't have any water that's coming out of it. The same thing from a cup, right? We can't pour from an empty cup. You probably hear on airplanes all the time, put your oxygen mask on first before you help others. It seems like a very simple thing, and it's hard to do. And I often encourage it, right, and planning around it. It's not only good for ourselves, but it's also really good modeling for our kiddos, especially our 22Q kiddos who sometimes struggle with their emotions, managing their own emotions, learning to regulate themselves. We can be really good models for them for how to do that. And sometimes that means that we build our own toolkit for calming strategies. And those might be different for your kiddo, and they're different from adult to adult, right? So some examples that I have here are, getting support from family, friends, spending time with those folks, and sometimes that means trying to have some time away from your kiddos so you can have that time to refuel. Sometimes that means doing something active, physical, taking walks, exercising, all those things can be helpful. Sometimes that means getting support for yourself from a professional. That's always totally okay as well. That's therapist, counselor, those kinds of things. And then the other two, which are tools that I often teach kiddos to do, but I think they work just as well for parents as well, is, doing things like taking deep breaths and learning how to regulate ourselves in those settings. And then how to shift our thoughts to be more helpful. I think those two strategies, again, are probably more cognitive-based strategies, but I introduce them because in our toolkit, we don't always have the time to spend, 2 hours with a friend over coffee, right? Might not always be doable. So we need a combination of strategies that are both require a lot of time, but some that we can implement and that are short and brief. Like taking deep breaths is something I could probably do in the middle of navigating something challenging with multiple kiddos at home. I could take maybe a few minutes to go take some deep breaths. And this other cognitive strategy that's up here, this one with the helpful thinking, right? So if I'm in the middle of navigating a tantrum, my go-to thought would be like, this is so exhausting. He does this every time we're going to leave the house, right? That thought is probably going to increase my frustration and anger in that situation. So I could try to reframe my thought. Not always going to be a rainbow thought, but it might be something like, my child is still struggling in learning how to navigate his emotions. That means I have to model for him how to take deep breaths, right? So that would be another kind of way to think differently in that scenario that might be more helpful for me to keep my oxygen mask on first and know how to respond in the moment. So anyways, I think I do encourage families to build their toolkit. You can encourage your kids to do the same as you're building your own, because it can help definitely with navigating different behavioral challenges. Okay, I'll pause there and see if there's any questions.
Questions? This is a microphone that you can toss around.
Can you go back to the slide what was saying anticipate and strengthen, like your positive relationship, daily structure? I didn't finish making notes on that.
Oh, which one? Sorry.
That one, where it says anticipate and strengthen, positive relationship, daily structure, clear expectations, and then there was like a second list on that, or two lists. Further back.
This one?
Back.
Oh, more.
Back.
This one?
Back one before this.
Oh, this one.
Yeah.
Yes, yes. So there are other in those charts that I provided. I probably didn't include all of these, so these are other ones that you could also consider for antecedent-based strategies. I could talk a little more about positive relationship. There are just different ways that we can do that, but it's this idea of catching the calm before the storm, right? Finding ways that your child likes to receive attention and filling that need. And that's also going to help you with that positive relationship. And I think I talked about some of the other ones: daily structure, clear expectations, and rewards. Yes.
And Dr. Cindy, if you can go back to that other one, we can just take a picture.
Oh, yes. Yeah, am I okay to move on?
Yeah.
Yes, okay. This one? Let me know which one.
Backwards. The first one, actually. One more. That one.
Oh, okay. I'm glad people know the slides very well. Okay, great. Yes, it looks like there's a question.
Not really. On the
Oh.
antecedents page,
Yes.
a timer is often way more helpful than just simply a voice notification that the kid's done.
Yeah.
Timer is super impersonal.
Yes, that's what I love. I love that suggestion. The timer, setting a timer can be helpful. Yes, a lot of times I have parents use like their timers or Alexas or Echoes to set timers. And
I had a chicken timer because
I love that.
that's all we used it for.
Yeah, I love that. And kiddo responded right away to the timer going off. Or Okay, but it's a good suggestion.
But it was helpful.
Yes, yeah, absolutely. Yeah, I think share like which strategies have worked with you for your kiddo, because I think in this room we can all learn from each other. But I love that. Thank you.
What are some helpful hints as hormones come in teen years that with the increased behaviors and outbursts or what have you that you've seen, because it's different addressing a little kid versus a teenager. What are some helpful strategies for that? Because that's very unexpected when those hormones hit.
Yes, yeah, absolutely. And sometimes it's very specific for every kiddo. I will say that one of the big ones for emerging adolescence is this top one. Positive relationship is a good one. Because like, as you said, there's hormones that are coming into play. They're probably increased irritability. Sometimes the parents are the least likely people that they want to spend time with. They want to step back and withdraw, spend a lot of time one-on-one, on their own, or with friends. And so if we let that kind of persist, sometimes we start to create a lot of distance, which can make that parent-child relationship even more strained and more challenging. So I often say, like, we want to focus on the antecedent piece. Again, it's not going to resolve everything that comes up in adolescence, but focusing on the positive relationship can be very, very helpful. With adolescents, that looks a lot different than with younger kids. It might be doing something that they like. Sometimes from parents and caregivers, they're like, they want to talk about this video game that they're really into, and it's really boring for me. And I'm like, if you can sit and listen, right, for those 10, 15 minutes, and they're just talking to you about this game, that's the quality one-on-one time, right? You're feeding that relationship, even if it's like extremely boring for you, right? Praise still works for adolescents. However, I would say continue to do some of that. And then find different ways that your teen likes to get attention or connect. Sometimes you can get a sense of that from how they connect with their peers, and then maybe figuring out if there's a way to do that. But I would say that antecedent strategy can be very effective as you start to transition into the adolescence, which gets harder and harder to do because teens are irritable and they're like, moody and probably not as fun, but it becomes even more of an important thing to do. Yeah. Yes.
Yeah, our kid is less than 2 years old, so we're kind of like seeing the future.
Yeah.
What age would be expected to see behavioral challenges that are specific to 22Q?
Good question. I would say it's so variable. It's so variable. So it's hard for me to give you a specific time frame. What I will say is for kiddos that I have seen since they're really young to maybe now they're about 5, 6-ish, sometimes I have parents start to bring up some concerns they're noticing around 3-ish, between 3 and 4. But that's not for every kiddo. And again, every behavior is going to look a little bit differently. But I think the common question I get is like, they're having a hard time really regulating their emotions, which is already really hard for toddlers, I will say. So I think that at that point, sometimes questions come up, but I would say the spectrum is so vast. And even at 3, if that was happening, it wouldn't be anything I would be like, we need to, that is super concerning. No, we'd probably just talk about strategies to help support the emotion regulation piece. And then it's just a matter of monitoring and following up with our team so that we could be screening for anything that might come up later on. Yeah. Does that answer your question? Yeah. Mm-hmm. I think, are we out of time? Oh, no.
I have a really broad, vague question, which is
Yes.
one of my very strong parental instincts is sort of concern about the slippery slope.
Yeah.
You threw the controller, that means I have to nip this in the bud,
Yeah.
which is sometimes effective, but usually not. But with the window on time theory, is that something? I'm trying to think of how to phrase this. Is the child even going to notice that recurring behavior with their sort of focus on the now? Is it the slippery slope less of a danger, of a possibility, because they're focusing on right now that they might not even notice? They threw the controller and then I took it away.
Yeah. So are they even going to recognize the consequence because their window of time is so focused on the now later on? The short answer is, you're right. Probably the first time around, no. And I think that that's probably why sometimes I get a lot of questions from parents and caregivers of like, we're addressing this behavior, but it keeps happening. And then, and at that point, you might still be very consistent with your consequence every time, but you're still not seeing a lot of change in the behavior. It's probably, like you said, to that point, is the window of time is so narrow, so they're focused on the now. And also, I tell families, like, a lot of our kiddos with 22Q do need a lot of repetition. And so it's going to be exhausting as a parent and caregiver to have to see that behavior come up, address it the same way, and just feel like you're kind of on a spinning wheel, right? And so I think my short answer to that is you're totally right. And consistency and continuing to do the same consequence every time can be helpful in the long run. Not immediately. It's not going to happen immediately because that repetition is so important for them, for their own learning, that I think eventually you will be able to start to see the shift in the behavior, but it doesn't happen right away. Yeah. Does that answer your question?
Very.
Okay. Yeah, good point. And I think our time is up. Thank you, everybody.
Thank you. That was so helpful. So our next speaker is Dr. De La Morena, who's going to talk about 22Q and vaccines, which is something that we get a lot of questions about.
Thank you. Wow, that's going to be very hard to follow, Cindy. I am delighted to be here and really wonderful to see many of you. It's been a wonderful and true privilege to be part of this 22Q team. So I'm going to change gears a little bit. This is a little bit of who I am. I'm originally from Madrid, Spain, but I've been in the States now for 30 plus years. I did my medical school in Spain, but then came to the States and did my pediatric residency and fellowship at UCS, University of South Florida. And I've been taking care of kiddos with 22Q for many, many years, and I've loved taking care of them. And at the beginning, we didn't have these multidisciplinary clinics, and so I felt that I was part of taking care of children by myself. So I can't tell you how much I love being part of such a wonderful group. I've been here now 7 years, and I love spending time with my husband when I get a chance to, and then we travel a lot. So in terms of plan for this talk, I'm going to give you a little bit of a historical perspective about vaccines. I'll tell you a little bit of how vaccines work and the concept of herd immunity, which is, I think, very important. We'll talk about the different types of vaccines, and then we're going to focus also on the safety of these vaccines for children with 22Q. So just to give you a historical perspective, this is Edward Jenner, and Edward Jenner is thought to be the father of clinical immunology. He was a family practitioner in northern England, and what he noticed is that the milkmaids would develop these lesions on their hands called cowpox, and yet they were never susceptible to the smallpox. They were sort of protected. So he was the first one to really recognize that this combination, that this protection of the cowpox and these lesions in these milkmaids could protect someone from smallpox. And so he published this variola vaccine. And really, the term vaccine comes from vacca, which is a Latin name for cows. And so what he did was take some of the lesions, he scraped these cow pox from the hands of the milkmaids, and then injected in children. And this is Philip Phipps, who was the first one, and there's a lot of pictures in that era. And what happened is that he really was the first to demonstrate that protection against smallpox. And smallpox was, if it went through a population, it killed 20% of individuals. So this was the first paper that really recognized that. And smallpox was eliminated from the planet in 1980. So it really took 180 years for when we started to being successful. And so in 1974, the World Health Organization requested, really by the request of many of the countries that were part of the World Health Organization, launched an expanded program for immunizations for all children around the world. And in 2024, they went back and looked at 50 years later, how did this impact survival? And what you can see in these, I'm not sure, maybe I can, oh, here it is. What you can see in these graphs, I'm just going to walk you through them. Pointer, here's the pointer. In yellow is vaccine, the measles vaccines. Here is the tetanus vaccines in orange. Pertussis is purple. Tuberculosis is blue. Haemophilus influenza is light blue. Polio is in green, and then other diseases. And what you can see here is deaths that have been averted in the past 50 years. And for measles, just an example, there's been almost 100,000 deaths that were averted with measles vaccination. And then here, the next two graphs are the life years that were gained and the accumulation of, I can't remember, I can't see very well, but survival. So if you take them together in the last 50 years, what has happened is that these vaccines have provided, have been able to save almost 150 million lives. So I think it's really important to think about. And this is just against 14 different diseases that we have tools to save lives. I'm going to give you a little bit of an example. This is the measles and prevention. And so this is in the United States, and measles was licensed in the 1960s, 1963 specifically. And what you can see is that the number of cases went from 500,000 in the 60s all the way down to pretty much nothing by 1985. Then there was some blips that started showing up, and that's when the second dose of the MMR of the measles vaccine came. And by the year 2000, until about 2020, measles was pretty much eliminated in this country. Unfortunately, there have been measles cases and outbreaks coming again. And this has really been occurring in pockets, and this past year there have been 3 deaths. Measles can be mild and nothing happened, but unfortunately, measles can cause severe brain damage and severe pneumonias, and people die of measles. And why is measles so important? And that is because if you look at the number of people that one individual with measles can infect is anywhere between 12 and 15. So you walk in and you have an exposure to measles, that if you could potentially infect almost 15 people with that just one person. So I think it's important to recognize the what we want to do is contain that, and anybody who can be and should be vaccinated to prevent not only their survival, but importantly to protect those who are very vulnerable and may not be able to be vaccinated. So now I'm going to switch gears and tell you a little bit about the immune system. I have to talk about the immune system if I'm an immunologist. But on the top of the screen, you can see is the skin in brown, and then underneath is the muscle. As if you remember, most of the vaccines, you're injecting it straight into the muscle. And you can see the syringe there and the vaccine. And what happens is that when you introduce, what you're introducing are proteins, and proteins are the ones that can elicit an immune response. And there are a certain number of cells that are these purple cells that have like little extrusions. They look like fingers. These are called dendritic cells. They capture that immediately, and then they go to the lymph node. And all of us who have seen kids with ear infections or a sinus infection or a sore throat, you can see how their lymph nodes here get swollen. Well, that's because that's an immune reaction that is occurring. And so there, these dendritic cells see, let me see if I, let's see, do you know how this works? I want to show, because this doesn't, okay, maybe here. Okay, so these dendritic cells in the lymph nodes have a cocktail party. And in that cocktail party, they're meeting up with T cells. And these T cells are called T. They're born in the thymus. And we'll talk about that in a minute. But these are T cells here. And these T cells then talk to another type of cell called B cells, B, born in the bone marrow. And these T cells tell these B cells, hey, I've seen this. We need to do something, and we need to produce antibodies to be protected. And so what happens is now all of these B cells then start dividing, and then there's 2 groups of B cells that form. Those that remember and sort of quiet down and have the memory of what they've seen, and then those that produce tons of antibodies. And these are the antibodies that go into circulation. These cells that produce antibodies, the B cells have been transformed into these cells called plasma cells. And then they go back into the bone marrow, stay there, and live for long periods, years. So they have, that's our memory box, if you will. And then the same thing happens with these T cells too. We develop also some memory T cells. So the whole point here is for you to remember that the goal is to make antibodies and to remember. That's the purpose of these vaccines. Okay, so then I'm going to switch gears. And what is herd immunity? So herd immunity is a concept by which vaccination prevents disease spread through this herd immunity. So let me show you here. Say that you have a person that is, has an infection like flu. Let's just talk about flu. And then all around him, nobody's vaccinated against flu. And so what happens, because it's so contagious, all of a sudden, if nobody is vaccinated, everybody can, except a few people there, but everybody gets infected by flu. What about if some people get vaccinated and you have the same individual that has flu? Well, you do have some advantage, but what you're trying to prevent is a disease that can cause serious consequences, you need to have a number of individuals vaccinated so that the spread can be controlled. So here you don't have the control. In contrast, if you have a percent of the population that is vaccinated, there is very little spread. So this is what that herd immunity means. So, for example, if you want to prevent the spread of measles, you need 95% of the community to be protected so you can contain it. If you don't have that, then it will spread. So, let's look at vaccines and the schedules. And these are the standard schedules, and I don't expect you to see all this, but just wanted you to know that you can get all of this. And at the pediatrician's office or your primary care physician's office, they have these schedules. The reason I teach my parents that the reason kids get vaccines at 2 and then 4 and then 6 and then they get boosters is because the immune system needs to see it so many times to develop the antibodies, to remember. It has to be reminded. So because the immune system is developing in this early age. So that's why we have the different time frames, and this is what you see in real life. So there are 2 different types of vaccines. There are those called inactivated and killed vaccines. What that means is that when you are giving the different components of that vaccine, you are not giving the illness, okay? You're not giving the disease. You're giving the components so that the immune system sees those components and produces antibodies, so when they see it in the real world, they're ready to go, okay? And this means these are the vaccines that are 2 types against viruses and against bacteria. And against viruses, it's your flu virus. It's your polio, the polio shot, not the oral polio. It's the polio shot, the inactivated polio vaccine that is now the standard in this country. It's the HPV vaccine. It's the COVID vaccine, okay? These are not, you're not going to get the flu if you get the influenza vaccine. It's very important to understand the difference. The bacterial types include the diphtheria, tetanus, and pertussis, responsible for whooping cough. Whooping cough is one of those terrible diseases that affects infants particularly, can also have significant brain consequences and damage, and can also have significant pneumonia. So whooping cough is not trivial. The Haemophilus influenza B, I'm old enough that I have seen children with epiglottitis die secondary to Haemophilus influenza. That's the Hib vaccine. The pneumococcal vaccine, when children come out of the womb, they get colonized immediately by certain bacteria that live in our upper airway. We have a relationship that keeps them under control. But if we don't make antibodies and we can't keep them in low numbers, they cause ear infections, sinus infections, pneumonias, meningitis. So that's why we're vaccinating to all of these. But all of these are killed. They're inactivated. They do not cause disease. You are making antibodies so that when you see it in the real world, you are ready to act. This is in contrast to the live vaccines. They're live, but they are weakened, okay? But what this means is that if your immune system can't handle it and you don't have all the steps and you don't have the T cells and the B cells, you could have bad consequences of these vaccines. So it's very important to understand what the immune system of each individual is, and in particular in our children with 22q, will they be susceptible to these infections if they get them? So these include the measles, mumps, and rubella. This includes the varicella vaccine, the yellow fever, and the oral polio. The reason the oral polio was removed is because children with severe immune deficiencies were getting polio when they were given the oral polio. So in the Western world and in this country, the oral polio was removed and substituted by the inactivated polio vaccine. BCG. BCG is against tuberculosis. It's given all over the world. The good news is that in children with 22q11 outside of the US, there's very, very, very low rates of complications with BCG. So, why is this important? Why is it understanding the immune status of an individual important when you're giving the killed vaccines? Because as we went through this again before, if you don't have enough T cells, if you don't remember, if you can't make the B cells make antibodies, and you can't produce these plasma cells, you now are getting a vaccine that doesn't have the ability of the immune system to handle it, okay? So it's very important to summarize. There are two types of vaccines, the inactivated killed vaccines and the live vaccines, which are weakened but could cause disease. Okay, so let's talk about the immune system in 22q. And I could talk for a long time about that. So I'm going to be very concrete, and we're going to just focus on a couple of things and how we approach our understanding of the immune system, and why is it every time you come see me, I start doing lots of tests. But one of the things that is very important, and Cindy brought this up, and that is every child with 22q is unique and different, and we can't compare each one. You can have general things. And Emily's first slide, did you see all the different things that could affect the midline? Doesn't mean that every child has all of these things. We like to put it all in one slide so that you can see all the possibilities, but every child is unique. So it's important that we recognize that. So similarly, the immunologic consequences are going to be different for every child, and we need to understand them. Very rare, but in less than 1% of kids, the thymus, which is one of those midline structures where the T cells, remember T for thymus, where the thymus develops, that sits smack on top of the heart. If they don't develop that thymus, there are no T cells. So those children have a severe immune deficiency, but that's less than 1%. And the good news is we can pick those kids up at birth before before they start with any type of vaccines, and we can start with medications that will prevent infections. About 60 to 70% of kids may have, you can see the thymus there, but it might be a little bit smaller. And I like to think about it as a bag of marbles. If you got a big bag, you have lots of marbles in there. If the bag is a little bit smaller, you have less number of marbles. So think of the T cells as your marbles and your bag as the thymus. So if it's a smaller bag, you have less number. But for the most part, those T cells are working okay. So that's important in understanding how that looks. And then there's about a quarter of kids that have normal thymuses, normal T cells, normal B cells. They make antibodies just fine. They don't have a problem with their immune system. And a lot, even though they may have some ear infections and sinus infection, their immune system is good. And it has more to do with the anatomical changes that is very obvious early on and gets better as the kids get older. So those of you may have experienced that. Maybe at the beginning they had a lot of ear infections and a lot of this and a lot of that. But, as they started getting older, all of that got better with time. And I just like to, so in terms of antibodies, are there kids with 22? We keep focusing on the thymus and the T cells. There are some kids that sometimes those B cells are not working very well, whether it's because the T cells can't talk to them very well, or they just have some subtle changes that may be important to follow. Those of you who have had children who have had congenital heart disease, you may have been told, oh, there's no thymus. Oh my goodness, there's no thymus. And then you come to me and I said, oh no, there's a thymus. And the reason I know that is because I can see if there's T cells in the peripheral blood. And the reason I know that is because the thymus sits on top of the heart. But sometimes, this is the normal, but sometimes it's up here. So when the surgeon goes in and is going to operate on the heart, you don't see the thymus because it's hiding up here. And sometimes it's up here, and sometimes it stays up here. Because during embryologic life, the thymus starts down up here and then comes down and sits on top of the heart. So I don't want you to worry if you ever hear that word. We will make sure, and that's easy to find out. And the good news is that all kids get newborn screening, and we know by newborn screening if there are T cells in circulation. So that's the important thing. Just wanted to point out this because that usually happens. So in your handout, there are the clinical guidelines for evaluation of children with 22q, and that is a very important paper. But from an immunologic standpoint, there are now guidelines, and there's a whole bunch of immunologists around the country that got together and said, hey, what about immunology? How do you follow them? How frequently do you test? How do you monitor their immune function over time? And so this is what came out back in 2022. And basically what you'll see is that when the diagnosis is made, we do tests. And we look to see if the T cells are there, and we look to see if the B cells are there, and we look to see if they can make antibodies. And around a year, right here, we look, because children should have been vaccinated, we tell you right here, can they get the regular vaccines? The inactivated, killed vaccines, can they get them? And the answer is yes. These are not live vaccines. And so by 12 months, when the MMR and the measles vaccines need to be given, we repeat the immune testing and we look, did they make antibodies to the vaccines that we've given? For example, tetanus. or the pneumococcus, because you've given those inactivated killed vaccines. And that's when we see what is the immune system looking like. And if the immune system is strong and well, then they can move on to these and kill the MMR and chickenpox. So all children with 22q should receive all the inactivated killed vaccine following the standard protocols. It's very important. You want to protect them. This is how you do it. All of them. When they're born, and the reason we get these first T cell counts early on is because rotavirus, which is one of the live vaccines that start at 2 and then 4 and then 6, is when we decide, can we give them the rotavirus vaccines or not, okay? But the measles and MMR, we wait. So all these killed inactivated vaccines can be given. Okay, so then what about measles and MMR? So there's been tons of study, and I'm going to highlight a few of them here and here and here. All of this to say that the reality is that kiddos with 22q handle measles and varicella pretty well, and they aren't having any difficulties. But we like to be very concrete, and we like to look at numbers. And these are the numbers that the guidelines suggest. If your T cells are greater than certain numbers, and that's what we check when we look at this, they're safe to get the vaccines. Can you get them together? Yes, you can get them together. Do we separate them out? Sometimes we recommend separating out, giving varicella first, waiting 4 weeks, and then you give the MMR. Why do we do that? Because about 5 to 15% of kiddos will get a rash with these vaccines. And so not just 22q kiddos, but all children. And so knowing which one is the one is helpful. Why? Because if it's varicella, you have treatment to give it. And so that's why we like to do it that way. But if your T cell counts are completely normal, you may not necessarily have to do that, and you could give them together without any problem. But that is my role, and that's how we work with the pediatricians and to help guide that. And then finally, many of you come and see me, and then we repeat titers over time. And this is a study that was done in Switzerland and looked at pneumococcus. And the pneumococcal vaccine, we give them at 2, 4, 6, and then we give them a booster. And then we sort of forget about it. Remember, the pneumococcus stays here, and we're constantly making antibodies. What we've learned over time is some kiddos with 22q, they lose these pneumococcal titers sooner than others. And so you will see that around 5 and then maybe at 10 years of age, I do check the pneumococcal titers, especially if they're still having ear infections and they're still having sinus infections, because I can give them a booster. And if they lose those titers, we can give them a booster. And similarly for measles, they tend to lose the titers a little quicker. So that's why we check when they're, around 10, sometimes 5, sometimes around 10, or adolescents. If they start, they should have gotten better with time. If they start having a lot of ear and sinus issues, we check that. Don't forget about allergies. There tends to be a little bit higher prevalence about allergies. But I'm not going to get into that. All of this was to say that the pneumococcal titers may wane over time. And so that's one of those vaccines that we would maybe give some boosters. And then, so just to summarize, vaccines are important. They save lives. Herd immunity is critical for the protection of many of us. And children with 22q can have variable immune differences, and each child is unique. So you need to know where your child is. All of the inactivated killed vaccines are safe, and the live vaccines requires the testing. And immune function and antibody levels we like to follow over time. So with that, I'll end, and happy to take some questions.
Hi, I have two questions. You mentioned that people born after 1990 got 2 shots of the measles vaccine, and before that it was just 1. So should adults be checked and re-vaccinated?
Yeah, so that's a great question. If you were born before 1960, I think 57 maybe, or 1959, 60, you don't need to be revaccinated because most of them have had, and that's the beauty of these diseases and what we've learned is that once you have the disease, you have antibodies that stay for a long time. Pregnant women are checked, and all healthcare providers are also checked to see if you have titers. You can check to see if you have titers. If you have titers, you're well. If not, you can be vaccinated as well.
Okay. And for the pneumococcal, you mentioned like the nose and the ears. Does that also involve the lungs or not?
Yes, so the respiratory tract. We like to carry these bacteria with us.
So we often hear that with flu and COVID vaccines, people like say that they feel symptoms. So if they're inactivated, why is it that people say they feel sick after? Because that was what my biggest fear of like getting the 2 on the same day too, is because we have enough things to worry about. So is that a true thing or is that a myth?
Thank you so much for that question. It's true. Why is it true? Because you're inducing an immune response, but you're not getting the infection. So it's just your body causing an immune response. It's all these T cells and B cells in the lymph nodes producing inflammatory markers saying we're going to respond to these proteins that we're being given. So yes, you can have fever. Yes, you can have malaise. This is usually short-lived. Yes, you can have a large local reaction, especially the pneumococcal vaccines could cause a large local reaction. The tetanus vaccines can cause large local reactions too. That's just your body, especially the local reactions, those memory cells, the moment you see it again, these memory cells quickly start dividing and quickly start making antibodies. So all these cells go there. And so then you have a large local reaction. It's warm, it's painful. You give cool, and you can use ibuprofen or Tylenol, and everything will calm down. But that's a normal reaction. We call that large local reaction. And yes, you can get the malaise, but there's no evidence that you need to separate the flu and COVID. You can give them together. I got him one in this arm and the other one in this arm. The flu didn't cause the COVID got, swollen, but the COVID did. But yes, you can have mild reactions. And yes, you can do anti-inflammatories or antipyretics like Tylenol, because that's a normal, that is the normal immune response that you're seeing.
We have 3 kiddos. One of them has 22q, and we noticed that he runs very high fevers. Do you see that a lot in the 22q populations, that they seem to run higher fevers?
Not necessarily. That's why I like to say everybody is unique. There are some kids that do just fine, and kids that don't have 22q, there are some kids that run high fevers too. Why that is, we really don't understand, to be honest with you. But if you know that's the case, be proactive, and maybe using Tylenol to prevent that is what is important, and talking to the pediatrician about it as well. But no, I don't. There's not that I'm not aware of children with 22q having differences in reactions that are unique to them against vaccines. They're just, from that standpoint, similar to children in the general population.
Hi. So my son's 5 now, but when he was born, I was one of the people that was told that he didn't have a thymus. Still to this day, I actually don't know where it is, but now that you've said that, that's great to know. I'm wondering if or how the size and location of the thymus affects the T cell count and how much they're producing and how over time that changes, because now that he's going on 6, it's gotten a lot better, but younger, like before 5, a lot of illnesses and things like that. So wondering that.
Yeah, wonderful question. We have, again, it's depending on each individual and depending on how big that sac is and how many T cells and how many T cells can be pushed out and how diverse those T cells are, okay? Because the reason these T cells come out in the peripheral blood is they're constantly sensing, and they're different. Each T cell can recognize unique proteins in bacteria, in viruses, in fungi. So they are so unique that they're incredibly diverse. So think about the bag of marbles and whether the marbles are all a different color or many colors. So that diversity, the many colors, is the diversity. So you may have very few T cells, but if they're all different colors, that means that they can recognize and see things, see many things. The difficulty is when you have less number of T cells and that diversity doesn't exist, okay? But children, for example, that were born without a thymus and have had a thymic transplant, if you look at those T cells, the numbers are small, but they're diverse. And so they handle things very well, even though the numbers are small. And many kids with 22q have lower numbers, but they handle things pretty well, you know? So there isn't a really good, these observations were noted in autopsy reports. And this is a very old study that was published in the 80s of where the thymus, and, you know, trying to understand it. But so the amount, once the thymus when we're born is big, and then it starts shrinking. And at my age, it's pretty shrunk and gone. And what we have is all these T cells out in the periphery that have the memory of what we've seen. And so the thymus involutes with age in all of us. In some individuals with 22q, the thymus may involute a little sooner. But that's why we monitor immune function over time, and we follow things over time.
Let's take one more question, then we should move on, okay?
So we have a daughter who's 27 now, but I remember when she was a baby, we couldn't give her the inactivated ones. So I'm assuming they must have done T cell counts on it, because eventually they told us it was okay to give her that. Should we be doing any extra testing on her now? I feel like now she just gets her vaccines, and I don't even think about if they're whatever they are. We just get them, and she's been doing okay. So
Exactly.
So you said it shrinks anyway. So yeah.
Yeah. So if once we've had MMR and chickenpox and you've handled it well, and some kiddos have had MMR and chickenpox and never got any type of testing because the 22q diagnosis was made much later, and they've just done fine. And the reason is because the majority of them will do fine. It's really trying to understand where you are. Adults with 22q are important to be followed. They need to be followed too. If they're having a lot of infections, we would want to see them because things may change over time. And so extra boosters might be beneficial. Mm-hmm. There's an increase, perhaps increased autoimmunity that occurs in some individuals, not all, in some. Arthritis or diabetes or other low blood counts that may occur over time. These are autoimmune. And the reason is that the thymus is also important not only to recognize what is outside of us, but to recognize our own tissues.
So you're saying that she's not having a lot of infection, she doesn't get a lot of, more than normal. So that's okay, but if she does, then have her get checked out?
I would.
Okay, and then really quick, Tylenol or ibuprofen after you get a vaccine, I've heard rumors that you should hold off on taking it so you get a really good immune response, or is that totally false?
I've not seen any data that supports doing that, and I don't think the general pediatricians recommend that either.
Okay, good.
Say that. Thank you.
Thank you.
That's great. So now we're shifting gears again, and we have Dr. Leonard talking about neuropsychological evaluation.
Hello, can you hear me? Is that close enough, or is the mic working? Yeah. Setting my timer. They work on grown-ups too. Well, good morning. I apologize for the mask. I have been a little sniffly and sneezy the last few days, and because I'm very passionate about not being one of the orange stick figures on Dr. De La Marina's slides, I'm going to keep the mask on. But I promise I brush my teeth and I'm smiling throughout the presentation. But I'm very excited to be talking to you all today about neuropsych evaluation and lots of other kinds of evaluations, as well as school-based supports. I actually don't know how we're advancing slides. Oh, we're doing it like that. So a little bit about me. I grew up here in the Seattle area, over on the east side actually, and I'm a proud UW Husky for undergrad. I went to Denver and trained at University of Denver and Children's Colorado for grad school, and then did my residency and fellowship down at OHSU in Portland. I've been back in Seattle and at Seattle Children's Hospital and part of the 22Q team for just over 4 years now. And like so many of my colleagues, I'm a big fan of hiking and skiing and all the Northwest things, and spending time with my family and my black lab. Okay, so today I'm going to try and cover a lot of ground, but I talk fast. I'm going to be talking about what neuropsychology is. I'm going to talk about the evaluation process, what a patient and family can expect from that process. I'm going to be talking about some other evaluations and services that are part of the 22Q clinic, or we might be referring to, that have a lot of overlap with us, and how to navigate which one you and your family need. And I'm going to be talking about school-based supports like IEPs or 504 plans. So first of all, what is neuropsychology? If you've never heard this word before, that's okay. Kind of sounds made up. I remember when I was in grad school and first told my parents that I was going to be specializing in neuropsychology, my mom's reaction was, and that's a real thing. It is a real thing, but there's a lot of misconceptions about what it is. So it is not therapy. It is not Freudian-style psychoanalysis. It's not looking at Rorschach ink blot tests, and it's not dream analysis. In neuropsychology, our tagline is that we are experts on brain and behavior relationships. And clinical neuropsychologists can sit in a variety of roles, but typically our role is in diagnostic assessment for things like cognitive and neurodevelopmental disabilities or disorders, which I'll provide some more information about that, and helping guide treatment plans. So a little bit about our history. Neuropsych does not cover the entire spectrum of psych assessment or cognitive assessment. Cognitive assessment and mental testing, as it was originally called, actually have roots all the way back to the late 19th century. We're a little bit more recent than that. Neuropsychology came about in about the 1970s. Before the 1970s, the living brain was really a black box. We couldn't know much about what was going on in the brain until after a person was deceased and we could take a look at it. But around the 1970s, there were advances in a few fields simultaneously that allowed us to take a look at the living brain. So for one, this is when we first started to see the rise of X-ray technologies, which gave us a really, really sketchy, literally fuzzy view of brain volume and structure. This is when we started to get EEGs or electroencephalograms that tell us about the electrical activity of the surface of the brain. And this is when we started to shift cognitive testing into neuropsych testing, specifically using results on performance-based tests to understand what is going on in the brain. So for example, back in the 70s, and still today, a neuropsychologist might receive a referral for a patient with epilepsy, with seizures. And the neurologist wants to know, can you tell me anything about where in the brain these seizures are coming from? So the neuropsychologist would run a bunch of tests of a bunch of different areas that we know are, a bunch of different skills that we know are associated with different areas of the brain. And if the neuropsychologist saw, okay, so they've got a lot of intact skills, a lot of like intact nonverbal visual spatial skills, but they're really struggling with right hand fine motor weakness. And their verbal skills are not as strong as their nonverbal. And they really have trouble with word finding or verbal memory. The neuropsychologist would conclude seizures are likely coming from or impacting the left frontal temporal area. You're not going to be quizzed on this later. But our job was really to localize dysfunction in the brain. But like so many fields, technology quickly threatened to put us out of business. MRIs coming out in the 90s really threatened to make neuropsychology a thing of the past. MRIs are more precise, more accurate than we could ever be with performance-based tests, especially with kids, because kids' brains are still developing and they do unique things when things go not according to plan. But we shifted gears and we tried to stay relevant. So there's a lot of different reasons why you might see, or your child might see, a neuropsychologist in this day and age. We can help identify cognitive or learning strengths and weaknesses, strengths to build off of, weaknesses that might need support. We can help determine the impact of the medical history on learning and development, whether that be a genetic difference or an anoxic brain injury due to a cardiac arrest or seizures or a stroke or whatever else. We still assist with the localization of function and dysfunction in the brain, where epilepsy is not super common in 22q, but it's more common in 22q than it is in the general population. So we still help with that. And we can provide diagnostic clarity, like is there a learning disability, is there ADHD going on here, intellectual disability, things like that. And a big part of what we do is help families and patients qualify for services, whether that be through the state, like Developmental Disability Administration services, or supplemental security income, or through the school, like through IEPs and 504 plans. So what does this actually look like? What should you and your kiddo expect once you get referred for a neuropsych evaluation, if appropriate? So this is what the process typically looks like. So when we receive a referral, the first place we're going before we even meet with you is the medical records. What might be we be on the lookout for based on what is in your child's medical history? So if I get a referral for a kiddo with 22Q, I might be thinking of, okay, I know there's increased rates of ADHD in this population. That's one thing I'm going to be asking the parents about at this next step of the evaluation, as well as a bunch of other things. The second step is an interview, typically just with the parent or caregiver. Sometimes the patient is involved with this. Neuropsych is one of the few services where we're going to ask you to not have your child at some of the appointments, because we're going to be asking hard questions about your child's strengths and weaknesses. And at the final visit, we might be giving results that are best shared by you and not us. So at that next appointment, we'll meet with the parent, ask a bunch of questions about development, learning, how school is going, IEP supports, all that good stuff. After that, we'll bring your kiddo in for testing. This is when they'll be doing those performance-based tests. I always say to kids, nothing hurts and nothing's scary. Well, hopefully nothing scary. I can be pretty scary. But there are no needles, no pokes, no scans. We're not putting EEGs on kids' heads. Almost never. But we are playing with blocks, we're solving puzzles, we're finding patterns, we're asking questions. It's working one-on-one, a little bit with the neuropsychologist, but more so with one of our psychometrists, who are master's level technicians, who this is their job all day, every day. They administer and score these tests. After that, the neuropsychologist is going to be taking all this information, interpreting it, making sense of what it all means, writing up a report, and then they'll meet with you a few weeks later to discuss the results, provide any diagnoses that might be appropriate, recommendations, and that written documentation that you can take to the school or the speech therapist or whoever else might be appropriate. I do really want to emphasize that neuropsych is not just the testing, and when neuropsych, I mean cognitive testing broadly, whether that's a psychoeducational assessment or an assessment with a pediatric psychologist who are all trained and qualified to do cognitive assessment and learning disability assessment. We're really looking at a constellation of data sources. So the medical history is, of course, very important. And our tests, our objective assessments, are an important source of information for us. But also what we hear from you, what these behaviors, what these difficulties look like in the home setting, in the school setting, that is incredibly important to us. We're often looking at school records like IEPs. We might be sending questionnaires to you, in some cases even to a teacher if we have a question that we need them to weigh in on. And then lastly, working with the child, observing their behavior is also very, very important, because we might get on our objective assessments, we might get a low score on a memory test, and we might assume, oh, there's something going on in their hippocampus. They're having trouble with memory. Well, if we actually looked at what was happening in the room, it's because the kiddo was having a tantrum and flipping the table over. A little bit of a different interpretation there. So understanding what the fidgeting looks like in the room, or the attention span, or the anxiety level. These are all really important things as we interpret these scores, which are squishy and not perfect. So what does the neuropsych evaluation cover? I like to be super, super transparent about this. In all of my 8 years of training, I never saw one of my supervisors just be transparent and open with families of like, this is IQ testing. And I am super transparent about that, and my team is, because I think families have the right to decide that's something I'm interested in, or that's actually not helpful for us right now. But intelligence, overall cognitive abilities, IQ, whatever you want to call it, is almost always going to be a part of the neuropsych evaluation. And we're screening other areas and going deeper into areas where we think there might be something that we need to explore more. So we are testing sustained attention and processing speed, executive functioning skills, which is just a fancy term for all the skills we need to set a goal and work towards it, like multitasking, planning, cognitive flexibility, things like that. We do look at language and communication skills. We think of speech as something in the mouth, tongue, and throat, and language skills as something in the brain, in the temporal lobes. Neuropsychologists do look at language and communication skills. We don't look at speech. Like we do attend to, this kiddo's having articulation difficulties. I'm going to make sure they're hooked up with my speech and language colleagues, but that's not our area of expertise. We look at visual, spatial, and perceptual skills. How are kids perceiving parts of a whole, shapes in space, things like that. We know that these are common difficulties for kids with 22q because of some differences in brain organization in the parietal lobes. We look at motor skills. Again, not our area of specific expertise, but we're really looking at it from a lateralization perspective. The right side of the brain controls the left side of the body and vice versa. So it doesn't come up very often with 22q, but if we have a significant difference, we might need to explore that more. More importantly for us is we know kids with 22q are more likely to have some fine motor challenges, and we want to make sure if appropriate, we're hooking them up with our colleagues in occupational therapy. We test memory. My postdoc fellow and I are in the process of doing this study with Dr. Gallagher right now. We're just waiting for approval to run this study, but I swear long-term memory, I know short-term memory can be a big difficulty in 22q. Long-term memory is a superpower, and we're going to be taking a look at that in our research in the next few months. We do academic screening. This is really not our area of focus. Insurance companies do not like seeing academic testing in our reports, but we sneak it in. We do academic screening as it does help us understand what kids need in the school setting. We will sneak in a full dyslexia eval when and if needed, but this is really the specialty of the schools and the focus of the school-based evaluation. We also attend to emotional and behavioral functioning. We rarely are giving diagnoses like anxiety or depression in this evaluation. It's really not a psychiatric evaluation, but we do attend to this because we want to know if we need to refer to specific services like Dr. Trevino or Dr. Conant, and we want to know if anxiety is having an impact on the test performance. And lastly, a big thing we look at is adaptive skills or daily living skills like self-care, navigating the community. This is coming from interviews and questionnaires with parents. We're not testing this with the kids because we want to really know, like, how do our scores, how does performance of these things relate to what's going on in daily life? So that's neuropsych evaluation, but that's just one kind of evaluation that might be recommended, that might be discussed at some point. And this all can be really confusing of what is the difference between an IEP evaluation and a neuropsych evaluation? What's the difference between neuropsych and neuropsychiatry? Neuropsychology and neuropsychiatry. There's a lot of overlap with all of these different services. And anyone on the 22q team can help guide you to the right service or the right evaluation for the question you have or the need your child has. But I want to go through these a little bit really quickly. So the IEP evaluation, if your child is getting a neuropsych evaluation, it's very likely that they have had or will have an IEP evaluation at school. This has a lot of overlap with neuropsych. We give a lot of the same tests. We look at a lot of the same things. We're just looking at it through different lenses. The school is looking at it through the lens of what do they need to be successful in the classroom? And we are looking at it through the lens of how are these test scores related to their medical history? But we're both making school recommendations. I want to really emphasize that neuropsychologists are not teachers. We're not special educators. None of us have ever written an IEP before. I defer to my colleagues in school psychology and teachers about these, but when I'm talking about this, I do know a little bit more than the average neuropsychologist, as I used to be a teacher, but a lot of times some of your questions we might be asking you to go work with the school, such as what accommodations does my kid need? What is the plan for after 12th grade? What are their learning goals for next year? Oh, and I'm behind on my time. Neuropsychiatry, Dr. Conant and colleagues. I know that sounds like a lot like neuropsychology, but we're actually covering very different things. I am not a medical doctor or a DO or a nurse practitioner. I don't prescribe medications. That is really for psychiatry. If you are concerned about is an ADHD medication safe for my child based on their cardiac history? Or is my child showing signs of bipolar disorder? These are questions that really, really take psychiatric expertise. And so I'll be sending you over to Dr. Conant. Dr. Trevino and I actually have the most overlap in our training. We're both clinical psychologists, and neuropsychology and ped psychology are just different specializations at the end of that long training journey. So we might be talking a lot about the same things. We might be asking a lot of the same questions when we meet with you. But I really defer to Dr. Trevino's expertise when it comes to what are the behavioral strategies this kiddo needs around their anxiety, or what are the reinforcing factors for this child's tantrums at school. Autism psychology, again, lots of overlap with neuropsych and behavioral psych and psychiatry. A lot of different providers might be weighing in on the question of, does my child have autism or not? Or what does my child with autism need? This is typically not included as part of a neuropsych evaluation. It's its own evaluation in and of itself. And we typically defer to the experts that do this all day, every day. Some of the neuropsychologists on our team, just 2 of the 8 of us, do autism assessments, so we might be able to cover that need for you in a neuropsych evaluation, but the cognitive piece is the priority. But we have a great team over at the Autism Center that can help with this. And so neuropsychology is really focused on what are my child's cognitive abilities, strengths and weaknesses, how is that related to their medical history? Does my child have a learning disability or a neurodevelopmental disorder? These are the questions we're most equipped to answer. I'm going to really briefly mention ADHD. I could also throw autism on this slide because a lot of different providers are qualified to answer this question if they have the right data that they need. Does my child meet criteria for ADHD? This might be neuropsychology, it might be behavioral psych or psychiatry, or through an autism evaluation, or it could just be working with your primary care doctor. ADHD is a behavioral diagnosis. It is not diagnosed by a blood test or a brain scan, or even performance on neuropsych tests. It is diagnosed through interviews with patients and families, questionnaires with parents and teachers, understanding what the behaviors look like in real life. And I will die on this hill. I'm always on my soapbox about this. I tell all my trainees, you do not need to do cognitive testing. You do not need to do performance-based testing to assess ADHD. And of all those domains that were on that list before, we actually know as a field in neuropsych, our tests of attention and executive functioning are our worst tests. They're what happens in the testing room has the least bearing on what happens in daily life. We see kids that are super motivated and want to do their best. They truly have ADHD, but they hold it together on our tests and it doesn't show up on the tests, and vice versa. We see kids that get really, really bad scores on ADHD tests. It's not an ADHD problem, it's an anxiety problem or a behavior problem. So you do not need testing for a thorough ADHD assessment. You need one of these providers to have the data they need, which is going to come from you and maybe the teacher. As well as a lot of kids are very well able to give us some data, whether behaviorally or through conversation. Okay, let's talk a little bit about school-based supports. This is really like the meat and potatoes of the recommendations that are going to come out of most neuropsych assessments. Recommending one of these 2 things if necessary, as well as specific recommendations in there at a high level way, not writing exact goals for like year to year, but more general stuff. 504s and IEPs are both school-based plans that provide extra supports for kids to be successful at school, but they are different in some very, very important ways. I like to simplify this down to a 504 does not change or add learning goals. A 504 provides accommodations for a student to reach the same goals that all the other general education students are working towards. So for example, if a child has ADHD and they're on grade level for reading, they're on grade level for math, it's totally appropriate for them to take the 9th grade geometry class, whatever else, but they need to sit at the front of the classroom and they need to get like the teacher's outlines on lectures so they can be successful. Those are accommodations. That's not changing or adding a learning goal. That would be a 504 plan. If a child has a significant speech or language difficulty and they need to get speech services at school, if a child has a learning disability in math and they need to be in a specialized tailored math class, those are changing learning goals. That would be an IEP or individualized education program or plan. This is synonymous with special education, but it can look a lot of different ways. And it is for students that have a documented disability under a certain category, at least one category, which I'll show in a couple of slides. And this is a legal document that shows the services and the instructional needs for the student. So to qualify for an IEP, you do have to be evaluated through the school. The schools can use the neuropsych evaluations to inform some of that, but they do have to do their own evaluation. And it needs to be documented that the learning goals or needs cannot be adequately addressed just through the general education setting, even with accommodations, and that additional services are needed. Kids can qualify under a lot of different categories. They can qualify under the category of autism, hard of hearing, blind, multiple disabilities. A lot of kiddos with 22Q or relatedly ADHD or whatever else might qualify under the category of other health impairment. This document should include the students' current levels of where they are towards their goals, whether that's speech articulation or math or emotional and behavioral goals. It should have documentation of how those goals will be assessed on an annual basis and the progress they're making towards their goals. IEPs can also include those accommodations, like this kiddo gets to sit in the front of the class, this kiddo gets to carry an EpiPen, whatever else. And I'll talk a little bit more about some of these other things on future slides. In terms of getting an IEP, it is very rare that the neuropsychologist is the first person to say that a student should get an IEP evaluation. The school is usually aware of that, but sometimes we're the first person. But any family can request an IEP evaluation. It needs to be done in writing. The school legally then has 10 days to respond in some way, whether that's giving you documentation of why they're not doing the evaluation or giving you the permission form. Once you sign that permission form, the school has 60 days to complete the evaluation, 10 days to write the report, and then 30 days to meet with you. That meeting will include an IEP team, which can be a constellation of a lot of different people. Maybe the principal, the general education teacher, the special education teacher, maybe a speech therapist, a behavioral specialist, a school psychologist. Lots of people might be involved depending on a child's learning needs. IEPs can also include behavioral goals and services. This is typically done through a functional behavior assessment, which is looking at the antecedents, behaviors, and consequences and functions of behavior, just as Dr. Trevino described, in a very systematic, data-driven way to create a behavior intervention plan to best meet the behavioral needs that might be interfering in a child's learning. IEPs need to be reviewed or revised at least once a year and reevaluate. And a reevaluation is required every 3 years unless the family and team agrees we don't need to reevaluate, that the goals and services are still appropriate. IEPs can also include things like summer services or transition to adult services. Some kids on IEPs will qualify for school-based services until they're 21, with those services really shifting after 12th grade towards life skills and job skills. All right, real quickly, 504s. Total opposite, just very loosey-goosey, very Wild West. 504s are different state to state, district to district, sometimes school to school. A 504 is sometimes half a page, sometimes it's multiple pages. It's just a plan for accommodations based on some physical or mental impairment. Truly, you can have a 504 if you have a bee allergy, because you need to carry an EpiPen. The evaluation process is also very unstructured. There's not a lot of laws governing this, but it typically involves a referral, an evaluation for what's needed, developing a plan, implementing the plan, and periodic checks to see how it's going. These are very brief and typically just include the accommodations and who's responsible for providing them, like accommodation might be that the child gets outlines of lectures, that's provided by the general education teacher. A child gets help with their diabetes management, that gets managed by the school nurse, things like that. Again, not changing learning goals. All right, sorry I went over on my time, but neuropsych evaluations are one kind of evaluation that can help understand cognitive, learning, and neurodevelopmental strengths and weaknesses, and provide recommendations, which is often very focused on school. I might have left you more confused than you were before about all the different evaluations and services that might be involved with your child's care, but truly, like, anyone on our team can help guide you towards the service that can answer the question you're hoping to have answered. And IEPs and 504s, the neuropsychologists, maybe the behavioral psychologists or the psychiatrists can all provide general accommodation or general recommendations for those plans, and the school can use that to design an IEP or 504 plan that's tailored for your child's needs. Okay, I think I am in Dr. Blessing's time, but Stacy, do we have time for a few questions? Okay.
Hi, I just wanted to say, just on that point of it being a lot of information, our kiddo is 13 and a half in 8th grade. Don't sweat it. You'll get there. If you have little people, it seems like a ton. Oh my gosh, how are we going to figure this out? There's whole teams within the schools. Just take a deep breath, you know. And my kiddo has, we cover the spectrum and all the different things that she needs. She probably has a team of 10 different support specialists. So, like, I just wanted to say that is a ton of information. And if your kiddo is 2 and 3 years old, it's gonna come down the line or whatever else, but it's less scary than it seems like.
I so appreciate you saying that. And I know my fast talking can feel a little anxiety provoking, but it is 1 year at a time, one step at a time.
What do you believe is like an age that is acceptable for an actual diagnosis of ADHD? We met with you for the intake and you were like,
Yeah.
You're so young, let's just wait. So
Yeah.
I'm wondering what that is.
That is such a good question. So the youngest I have ever diagnosed ADHD myself is 5. I usually prefer to wait till 7 or 8. I have seen other providers diagnose as young as 4 or 3, which I don't agree with. The general consensus in the field is that 5 and 6 are early, but not too early. 7, 8, 9, that's when we can really distinguish, like, this is typical child development plus a little bit versus, like, this is a true neurodevelopmental difference that needs longer term supports. But it's certainly a controversial subject. But my personal thought, 5 or 6, early, not too early. 7, 8, 9, I'm very comfortable making the diagnosis if appropriate.
Hi.
Yeah.
So we recently, this year, we did the neuropsych evaluation. Do you recommend repeating that after some amount of time?
Yeah, that is a great question. And the answer is, it depends. If I think if it was me, if I did the evaluation, it should be in the report if we're gonna repeat. So it really depends. The field has kind of moved away from just standard, we're gonna redo this every 2 to 3 years, and that's for a couple of good reasons. These things are pretty stable over time. If we diagnose an 8-year-old with ADHD, we don't expect it to be gone at 18. We expect it to look different, but we don't. These cognitive abilities after 7 or 8 tend to be pretty stable. So we don't like to torture kids, and we can just meet for a consultation to update recommendations. 2 insurance companies really fight us on this. Some insurance policies have or some insurance companies have a policy that this evaluation is once per lifetime per patient. So we have to be really strategic about if we do it. If a kid's first evaluation is 6 or younger, we are probably going to say we need to see you back in a couple years because we're not super sure about anything at 6 or younger. If kids are 7 or older and we are providing clear things, we might be saying you don't need to come back and see us. It's not standardly ongoing. Yeah. Yeah.
Good morning. I have a question regarding the information that the primary care provider have. For my daughter, when I go out and I'm asking the primary care providers and saying that, okay, my daughter has 22q11, she looks at me, what is that? And or I say, oh, that's D. George. What is D. George? So I have to describe and tell her what that is. And the other day we went to other doctor for, what was that, for orthopedy or something like that. The same question, what is that? And then he was looking into the internet and to find out what I told him, that was correct. So how can we inform the other doctors outside Children's Hospital what it is about? And the other question is that, because my daughter is now 20 years old, so we are in transition. So she has to transition to UW. And now they don't have any 22q department. They have for autism, which is totally different than what 22q11 is. So I don't feel well about it because here I think I was always in good hands. Somehow I'm worried about it. So these are my 2 questions. What should I do?
Yeah, so those are wonderful questions, but Dr. Blessing and Dr. Stobie are actually about to speak directly to those things. So I'm going to respectfully defer to the first question about this provider has never heard of this before. I mean, and that we hear that all the time. That's the reality when something is a rare disease, is that your general pediatrician or another provider may have never heard of this. I think, and I don't know if you all are talking about documentation at transition, but I know that if your child has a neuropsych evaluation, that the whole goal of a neuropsych evaluation is let's get you a piece of paper, or 20 pieces of paper that summarize your medical history, summarize your developmental history, and whatever else might be important. So you can use that as a tool. Here's school, here's what you need to know. Here, primary care doc, here's what you need to know.
Sorry about my disruptive back and forth, but I'm on call and I have a few things to take care of over there. So next up we have Dr. Blessing and Dr. Stobie talking about transition to adult care.
Hi everyone, I'm Dr. Blessing, and Dr. Stobie, I'm really excited for him to join me. So just a little bit about me. I grew up in Michigan and was at MSU for undergrad and med school, so I felt like I needed to branch out. So I interviewed all over the country, and it was absolutely pouring when I got here. But then the sun came out on the second day, so I love it here now. Been here a long time. Yeah, my wife and I and our son and very old cats live here in West Seattle. And I have a weird array of hobbies. And yeah, I ran for the hills after residency and left the hospital for 11 years. So I have a perspective of having been in primary care for a long time prior to coming back to the hospital to get more time per patient. So yeah, that's a little bit about me. And I'm really glad you came up because I didn't know how I was going to.
Yeah, I didn't want you to have to do that. Well, hi, everybody. I'm Gary Stobie, and I'm an adult neurologist by training. And a neurologist, I specialize in an area of neurology called cognitive behavioral neurology. I grew up on a little farm in San Joaquin Valley in California. I loved watching animal behavior. Then had an aunt with multiple sclerosis, lived with my family in my teen years, and I got really interested in the science behind human behavior. Went to UCLA undergraduate, Albany Medical College for medical school, and back to UCLA, and moved up here in 1993. I've had my best training by my 4 adult daughters, who are now adults, and my grandkids, and all of you guys. I'll be talking later, about why things kind of decline when we become adults for our services for you guys. So, but great to be here today. Thanks.
So your questions couldn't have been more timely, so we know we have a lot of work to do. So that's kind of our goal of our talk today, is to talk about what we're trying to work on to improve the preparation for transition to adult care here at Seattle Children's and in the 22Q Center. And then also, because, like primary care providers are so I think really critical, but possibly even more so in the adult world in terms of connecting resources for medical complexity. But if you don't have that trust, and if they don't know a lot about the condition, then that can be it'd be hard to build that trust. And so we're hoping to develop some tools to improve that. And then I'm going to highlight a very specific one of those with the 3rd bullet point here. And then I want to very much emphasize that I'm not an expert on guardianship or less restrictive alternatives to it, but just kind of touching on that our whole team, like Dr. Leonard's expertise from his assessment, and then social work, all sorts of folks on the team can collaborate with you to make the best decision for you and your adult child. Okay. And so first, I'm going to touch on what we're trying to do here a little differently in 22Q clinics. We're really very much in a pilot program right now, and I put some of the things I put on this slide are to talk them into existence because we're trying to work on them. So, for example, like with our preteens, we're actually thinking with our very young, infants and toddlers and up, to develop clinic passports, which do not yet exist, but I really want to have it be more fun and educational, where more not like a small passport, but maybe more like a binder where there's both some fun stickers or stamps that the child can get when they go to the audiology booth, which can be a scary experience for young kids, but also some educational info for the kid and caregiver about, yes, we do see slightly higher rates of ear infections, things like something that might be relevant to that area. I'm also just personally trying to work harder on talking directly to the child. I feel like I've always been fairly good at that, but really trying to work on it lately. And then starting earlier with, I think that understandably we develop a really strong bond, but even if you live in Bothell, my availability is crap in clinic. So if you have a rash, your primary care doctor hopefully is a lot more accessible than me for addressing that. And so developing that trust that they are really wonderful at other stuff besides 22Q, and then maybe we can help them learn about 22Q and partner with them. And they also know about the local resources in Spokane or Idaho or wherever you are that I don't know about as much. And then in the early teen years, we're also, the hospital recently improved MyChart access for teens and improved how the caregiver's MyChart access works when your child becomes a teen. So it used to be like you lost a lot of access, and it's better now for what caregivers have when your child reaches 13. And we can explore having it be full access when developmentally appropriate, depending on your child. We're really trying to, as appropriate and as the child feels comfortable, get the kids to take the lead in clinic. And maybe I'm trying to ask them first, like what their concerns are, and gently remind them like what my role is, because a lot of them are like, who are you, and like what is this clinic for, and so I'm like talking about that up front. And then also starting to really open up, I said healthcare plans, but really trying to start discussion earlier about long-term life plans beyond 22Q clinic, which is, I want to reassure you that also that this pilot program is not to put a time limit or cap. We kind of have like a cheesy phrase that Christina Parrish, who now is in Finland, but she coined the term transition in 22Q by 22. But there's not a time limit even at 22 years old. But I do think a lot of our young adults are starting to feel ready around 22-ish, but there's no rule there in our clinic. On the other hand, other specialties do have a strict rule, like pediatric dentistry. If your child is getting their primary dental care here at Seattle Children's, they do cut you off at 18. So that's the kind of thing where we want to try to plan ahead a lot better than we have in the past for the kinds of issues that you were mentioning. And then, and the later teen years, or mid to later, starting to talk about, like, what are you planning on? Are you going to go into the extended high school program to 21? If you don't feel like that's the right fit for you, exploring like the Department of Vocational Rehab that the state and counties provide. And then we do certainly have some patients that are enrolling in post-secondary programs like vocational training or college as well. And then we have to start talking more directly about, like, is your primary care provider a family medicine provider who can keep staying with you, or if they're a pediatrician, do they have other members in their office or a nearby office that they really trust? Because they are dealing with that transition all the time then, and would have usually they have a better idea than I do of who's best. But if it's local, I also can play a role, and our team can play a role in trying to identify the ideal candidate for that. And then we, for the first time, start to do what's called a transition readiness survey, which I have another whole slide dedicated to it, but it's starting to kind of just ask teens, like, how comfortable do you feel with these categories of things that you could take the lead on? And they're like, what? And then we repeat it later. And then Maria, our amazing genetic counselor, can start. We really want her to meet with every teen or young adult in our clinic before they leave, so that she can provide education on what 22q deletion or duplication means for them in general, but also in terms of family planning potentially. So that could be here or here. And then for our young adults, then okay, have we identified that PCP, and either they or I or our team can help with referrals, like, let's say, because as Emily touched on at the beginning, like our 22Q clinic, you may have other specialists that are not like endocrinology, cardiology, that are not in our 22Q center, but we can absolutely help with referrals to them, or your local primary care doc, if you're outside of this area, may have a stronger knowledge base than I do of where this is a great endocrinologist that's right here in this part of Eastern Washington, or wherever you may be. And then another thing that you touched on with your question is, this is something that we really want to work on, is having a portable medical summary. So something that's maybe a little more simple than the 20 pages that Dr. Leonard will give you, but something trying to summarize your child and now young adult's life medically, that you can say, hey, like this is, hey, primary care doc, hey, emergency room provider who's rushed, hey, new adult cardiologist, this is our history. And so it's a combination of the 22Q nursing and pediatric team that we're trying to develop a draft of that as you're getting closer to transition. And we can even give you like one earlier and then work on and and perfect it before you, and then even if, I guess another message is even if you are done, you can always reach back out to us if your child is 27 years old and you need a clarifying point, like, hey, like this is coming up, you can always reach out to us. And then we have social work supporting at every age through this idea of working on transition. Here's that transition readiness assessment questionnaire. It's hard to fit it on a slide, and it looks a lot nicer in clinic because they've actually integrated it into the iPad during the check-in process. I think one teenager even told me that they got it in my chart and she filled it out ahead of time. It was like a telemed visit. It was amazing. And so, but it's not to scare the kids, but just to like, just these 4 areas, just kind of like maybe setting stretch goals of like, if there's something that they feel like I'm not doing it, but I'm learning how, or I'm interested in learning how, just setting a goal or 2 that's developmentally appropriate for them. And I know that it's like Dr. De La Morena said, every kid is very unique. So some of these may be not appropriate for your teen or young adult to do, but for many of our kids, they feel really empowered by starting to try to do this. And then our goal is to reassess it 2 to 3 times in their later time in our clinic, like once a year or so. And this is free online, by the way. So it's like, I actually just had to get these, I just had to email the guy who created it at like, I think East Tennessee State University. And he's like, oh yeah, here it is. And like, very open. So, and then I know I'm a broken record. So as a former primary care doc, I've touched on this a lot, but I think some primary care doctors are more curious and patient and somehow find the time than others. And so I know there's a lot of variety out there, but if you find one who is willing to learn, they need to have humility. And yeah, I was shamelessly looking things up on the internet in front of patients all the time for those 11 years and like would be very open about that. Like, yeah, I have no idea what you're talking about. I'm gonna take a moment and I'll be right back, or I would just do it with them in the room. And then sometimes I would need to, phone a specialist friend, and it's hard because they don't have the protected time to do it, but they got to do it anyway. And they have to be your strong advocate in the adult world too. And then they and their medical assistants are more trained up than the medical assistants at Seattle Children's for all of the vaccines. So it's actually the best place to get your full vaccine schedule is at primary care. And then they can, again, be a really strong advocate for you. I've touched on this. Yeah, I think sometimes I was in a pretty nice situation where I could advocate for, my standard was 20 minutes. I also had 40-minute slots for some patients. If I didn't abuse it, they didn't come after me. And so you could advocate, like, is there any way that my young adult could have longer visits with you? And some of them might have that ability. And then if not, then some families are willing to just schedule more frequent visits, which is kind of not ideal, but just having a quarterly check-in instead of like, oh gosh, it's been 2 years and I don't know them, I don't trust them. So maybe more frequent visits is an option with your primary care provider. And then, yeah, we've talked about all that. And then this is the document that it's actually, I think, included in everyone's folder today, but it's also open source on the internet, which is the updated clinical practice recommendations for managing adults with 22q deletion syndrome. And there is one for pediatrics too that like Emily is like an author on it and stuff. But for the adults, that is a really nice one to give to your primary care provider, but I think to have copies also for specialists. it's frustrating that there's less data available for the duplication so far, even though it might be as common or more than the deletion, and maybe just we don't catch it as much. But it seems like kids with the duplication are at some risk of similar complications to the deletion. So we could potentially tailor something, or you could even use this document. But I think that's where I think we need to really leverage the portable medical summary. Like, this is my child with duplications needs. And then on guardianship and less restrictive alternatives, I think this is where I really lean on our social work experts to help. And then it's a very I think this is where we really need the multidisciplinary team and the caregivers' help to determine like what is the best situation for my young adult with 22q deletion or duplication. And Dr. Conant highlighted to me that something I didn't know, that like the legal fees for helping with the paperwork, it's something that is worth planning on as your child is approaching adulthood. And then if that's not realistic for your family, we could talk with social work about what alternatives there are. A lot of these resources were things that were shared with me when I sent out a help email for this slide. And so I've included a lot of QR codes with great resources in the paperwork. And one thing I'll highlight that I learned about at the ACPA conference last spring is like a supported decision care model. So sometimes a supported decision where there's a legal setup where your young adult and you have supported decision making, it's less restrictive, less rights are lost than guardianship. So that could be an appropriate alternative for many children with, young adults with 22q. Okay, yeah.
All right, great. Thanks, Dr. Blessing. So I'm just going to talk for about 5 minutes. I will be around during the breakout sessions, so happy to discuss more things then. I've been doing a lot of work. I worked at Seattle Children's at the Children's Autism Center from 2008 when it first opened till about 2 years ago. The adult world has expanded and is now taking up kind of all of my time. I still do have a little bit of time out at the Alyssa Burnett Adult Life Center in Bothell that's run by Seattle Children's. It's an amazing program. I was, when I went into neurology, the focus of most neurologists are on acquired conditions or degenerative conditions. So things acquired like multiple sclerosis or traumatic brain injury that occur in your adult years, or degenerative conditions like Alzheimer's and Parkinson's disease and such. I struggled with that, and I really got drawn into neurodevelopmental conditions because people over time, when they have amazing folks like you and their families supporting them, folks with neurodevelopmental conditions make progress. And this was something specifically around autism that we weren't taught in our residency when I was in training, that with the right supports, people make this nice, kind of steady, ongoing progress, especially from the years of like 20 to 30. Just really amazing progress when there's still fuel in the tank. And that's you guys, because as you probably have heard, things kind of drop off after the school goes away. And this program that Seattle Children's has built with your support is an amazing program. And so I appreciate your comment about the fear that you face in transition to adulthood. And I would encourage you, even though you have that fear, that the method of putting your head in the sand like an ostrich is not the best approach. And being prepared and really setting up this thing that we call kind of a person-centered plan. And really taking the strategy of being person-centered and strength-based. And one of the best things, one of the advantages I've had over the years is partnering with self-advocates, folks that are now adults and are informing us about their younger years and what we could do differently. And the one thing that has resonated over the years is, if you could, for a 30-year-old, let's say, go back in time to age 12 or 13, and what would you tell your parents and teachers knowing what you know now? And two things have resonated with that question. One is the comment, I wish you would have taught me to self-advocate at a younger age. I think that's these efforts that we're talking about in these teen years to start to include your child in the decision making, right? Giving choices, you know, in those strategies. And then the other one, in addition to self-advocacy, is I wish you wouldn't always focus on the negative. You know, and it's really the strengths, it's these superpowers that are going to get the folks to the things that they want to do. So that person-centered plan is all about that, putting the person in the center and thinking, helping them think that window of time, because often their window of time is narrow. So you have to come in and help them think about that future. What is your goals? And then how are we going to get there? And how are we going to build that plan? After school ends, you guys remain the center, the focus of the care management for the person. And it's not fair, but it's the reality. When I had 4 kids, I thought they were going to be gone at age 18 and I wouldn't have to worry about them anymore. I don't know where I read that, but it's not true. And I think that, but it's also super important that you learn how to give more independence over time. And that's hard. When you come from this world where you guys have had to be on top of so much stuff, to be able to allow your adult child to make mistakes is a hard thing as a parent. So you're working on your changes also as your child becomes an adult, right? So this is what we do in our clinic. I appreciate the comment about our name being the Adult Autism Clinic, not properly representing what we do at University of Washington with our clinic. Most of our folks that we see do have autism, but we really deal with neurodevelopmental conditions that include autism. And so we're going to be renaming our center to the Adult Neurodevelopmental Wellness Center hopefully next year. We've got, we're building services. We're not going to be anywhere near what you guys have here, but hopefully over time we're going to be able to kind of continue to build a lot of emphasis on helping teach non-specialists. There's never going to be enough specialists to do this work. We have to bring in family medicine. We have to bring in the neurologists that don't do neurodevelopmental work. We have to bring in the psychiatrists that don't do neuropsychiatric work. So we have a lot of work ahead of us for professional training. You know, my North Star is we live in a society where everyone is welcome everywhere. And we're not even there in the medical system. So we got a long way to go. It's not going to happen in our generation, but we can make progress. And I've seen progress just in the time that I've been doing this work. So I still am enthusiastic and excited about the future. And I look forward to meeting you guys as you come over to the adult world. So thank you.
I think we can take just a few questions if anyone has questions before we start to break for lunch and transition to discussions.
I'll try to just project, but I really appreciate this presentation. I have a 15-year-old daughter, and you guys make me feel so good because she's definitely advocates very well for herself. But one of the things that she just came up with this year is she said, I don't want to go to the 22Q clinics like anymore. I don't want to go to the horse camp. I don't even want to go to speech therapy anymore because I've worked so hard and I can't make any more progress. And I've decided I don't want to be defined anymore by 22Q. I want to be a kid. I want to branch out. I want to see what I can do. And so I love it. I applaud it. But I'm also like,
Yeah.
you're taking the training wheels off and I don't know what's going to happen. So what's your advice? Like, how do I manage a middle ground? I'm like, okay, absolutely. But inside I'm like, okay, what's the middle ground here?
Oh yeah, I think that's a really challenging one and encouraging too, because I think it's like very appropriate teen behavior. So I think, you know, I do think one thing that comes to mind, which I'm nervous to say, but like I do think occasional therapy breaks can be okay and empowering. Like because sometimes families and teens or younger kids are exhausted and families can notice when their effectiveness has dropped off, and like sometimes a break and then return can be great. And then I think acknowledging the frustration that she has to deal with this extra clinic and slow doctors and multidisciplinary, you know, it's like a long day. I think acknowledging it is helpful, and saying, you know, like we hear you, but we want to just make sure that everything as you because 22Q is just one part of you. They can help to focus on how we can get you fully supported in the adult world, but it's hard because she's more focused on the now, right? So I think that would be partially our job to kind of try to make it relevant to her while she's in clinic. But I don't know. I'm looking at Cindy for how to get her to clinic a little bit.
They're working together. So.
Awesome.
And I think that's what she's done.
Yeah. Yeah. Sure.
Two things. First of all, to reinforce, our daughter's 30. I don't know, mine's the oldest here, I don't know, but, and I do want to say, Dr. Blessing, we've never been in the kids clinic. We moved here after she was an adult. He did help us find an amazing PCP who was willing to learn, didn't know anything about it. It was like being saved from drowning, and then we lost her, and we drowned again. We have since found her again, so all good. So I do want to say, as somebody who lives an hour plus away from Seattle, amazing, and you can't do this without somebody who knows this stuff. You just can't. The other thing is, to the adult clinic, I'll just ask, is this something we can just call up and say, we've never been at Seattle Children's as a patient, part of the clinic, and boy, do we need help. We need help.
Yes, you can. Just be prepared. The answer you're not going to really like right now, which is that we have a 3-year wait list to get into our clinic. So, and the trouble is the messaging. We are such a small clinic and such a large organization. It's really hard because you often get a person on the phone that doesn't know the details. Okay, so I would say for everyone in this room, your backup is reach out to these guys. Okay, even at age 30, they'll make backdoor reach out to us, and we'll make sure that things are kind of lined up. So that's not the best way. That's not the way that we want to be eventually, you know. But that's kind of the reality right now. So I apologize ahead of time.
30, we totally get
Yeah,
it. It's
yeah,
been a lifetime of that.
yeah, yep, yeah. That's.
But you're here. But we're here. I'm excited. Yeah. Okay, we got you.
Any other questions? Okay. Thanks, everyone.